Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's resume our playlist called Microbiology and Infectious Diseases. In the previous video, we started talking about the characteristics of Group A beta hemolytic Streptococcus, aka Streptococcus pyogenes. Pyo means pus, genes is from genesis, to generate something, to form pus. And therefore, it's not going to be shocking when you learn that Streptococcus pyogenes can cause infections with pus, such as in your throat, pharyngitis, or in your skin, pyoderma. Please watch the videos in this playlist in order. I have two playlists about microbiology. The first one is just called Microbiology. This is a very quick summary. The detailed discussion is in this playlist, Microbiology and Infectious Diseases. Just like we did with Staph aureus, we'll do the same thing with Strep pyogenes. The same bacteria will be discussed in 4 different lectures. The first one was classification. The second one was characteristics of Strep pyogenes. Today's lecture is about the diseases, the clinical picture of a patient infected with Group A beta hemolytic strep. In the next video, we'll talk about diagnosis and treatment options for Strep pyogenes infections. For maximal understanding and retention, please watch them in order. These are gram-positive bacteria. Is Streptococcus pyogenes a coccus or a bacillus? You just said Streptococcus. It's a coccus. It's a sphere that is gram-positive, i.e. purple, by using the gram stain. And then, based on the catalase, does Streptococcus pyogenes have catalase? The answer is no. All of the Streptococci lack catalase. And then the next question, hemolysis. All right, when I put them on the dish, are they alpha hemolytic, beta hemolytic, or gamma hemolytic, meaning no hemolysis? The answer is they are beta hemolytic. The next question, are they sensitive to the antibiotic bacitracin? In other words, can bacitracin kill them? The answer is yes. When we say Group A beta hemolytic Streptococci, we're using 2 different classifications. We say Group A based on their Lancefield classification. This is a serological classification. When we say beta hemolytic, we are referring to their hemolysis capabilities. So Group A beta hemolytic Streptococci are also known as Streptococcus pyogenes because of pus. We are here, Streptococcus pyogenes. We have many pus infections, including the pharynx, including the skin, and we have some immunological complications such as the famous rheumatic fever, affects your heart, and post-streptococcal glomerulonephritis, which affects your kidneys. Please understand the difference between staph and strep. Staph had staphylokinase, strep had streptokinase. But what's the difference? Well, they are basically the same. It's the same fibrinolysin, just the name is different. What's unique about strep is that your body will make specific antibodies against the streptokinase of the streptococci. And we can use this in the lab as an identification test. Streptococci do not have coagulase, but they do have hemolysin or streptolysin. We have 2 types, S and O. Again, your body can make antibodies against the O streptolysin, and these are known as anti-streptolysin O antibodies, also used as an identification test in order to diagnose you with a streptococcal infection. Same thing applies for DNase. There is an antibody known as anti-DNase B antibody. A third identification test. We concluded the last video by summarizing the virulence factors of Streptococcus pyogenes, which included structural components, the most famous of which is the M protein, and the toxins, the most famous of which is the erythrogenic toxin. The word erythro means red. This is scarlet fever because you are feverish and you have a rash. Red rash, that is. Scarlet means red. Erythro means red. It's a freaking super antigen. Super antigen binds strongly to macrophages and T helper cell. Phew! Before you know it, cytokine release. This can be responsible for scarlet fever, streptococcal toxic shock syndrome, aka toxic shock-like syndrome, as well as necrotizing fasciitis. Strep pyogenes also possesses enzymes such as streptolysin S, streptolysin O, clinically relevant. Also, we have streptokinase, the famous TPA, clinically relevant, and DNase with your anti-DNase antibody, clinically relevant. Today we're not talking about the characteristics, but the diseases caused by Streptococcus pyogenes. We divide them into two big groups: suppurative diseases. What does suppuration mean? Pus formation. And non-suppurative diseases. Pus or no pus? This is the question. The suppurative diseases include diseases in your throat, pharyngitis, diseases in your skin, pyoderma, which include impetigo, erysipelas, cellulitis, and streptococcal toxic shock syndrome, aka toxic shock-like syndrome, to distinguish this from the toxic shock syndrome caused by Staph aureus. So toxic shock-like syndrome is Staph aureus. Toxic shock-like syndrome is Streptococcus pyogenes. What if I have a disease that has throat infection and skin infection? This is scarlet fever, here in between, in the middle. Other suppurative diseases caused by Strep pyogenes include puerperal sepsis or peripartum sepsis, pneumonia, and lymphangiitis. Can Streptococcus pyogenes cause bacteremia? Yes, especially if you have toxic shock-like syndrome or necrotizing fasciitis. Bacteremia is less likely with throat infections and superficial skin infections. But as you get deeper, you're more closer to blood vessels. Therefore, bacteremia becomes more likely. Bacteremia means bacteria in the blood, lots of them. The non-suppurative diseases are usually immunological reactions, and they include rheumatic fever in your heart, post-streptococcal glomerulonephritis in your kidneys. Let's dig deeper. Throat infection, this is pharyngitis. It's a pharyngitis with pus, so it is suppurative, exudative pharyngitis, also known as strep throat. How about scarlet fever? I have pharyngitis and I have a rash. Who started first? The throat infection, followed by the rash. And even the rash started on the upper chest first and then to the extremities. What kind of rash is this? Sandpaper-like rash. Moreover, scarlet fever has strawberry tongue, circumoral pallor, which means you have rash everywhere but not around your mouth. Around your mouth is pale, no rash. And you also have some pastia lines. More on that later. Next, skin diseases caused by Strep pyogenes. Of course, they are pussy, and they include impetigo, erysipelas, cellulitis, necrotizing fasciitis, and streptococcal toxic shock syndrome or toxic shock-like syndrome. Impetigo does not have systemic symptoms in most cases. However, erysipelas, cellulitis, necrotizing fasciitis, and the toxic shock-like syndrome, all of them have systemic signs, and they can vary from mild, like some headache, feeling on the edge, to severe symptoms of multi-organ failure and death. We're talking heart failure, kidney failure, liver failure, you name it. Erysipelas affects the skin alone. Cellulitis is skin and subcutaneous tissue under the skin. Necrotizing fasciitis is the skin, the tissue under the skin, the muscles and fat under the skin. Oh, this is getting deeper. Yeah, you can get bacteremia, you can get toxemia, you can get shock, multi-organ failure, and death. This is known as streptococcal gangrene. Oh, this is severe. This requires us to call the surgeon to perform debridement. This tissue is gone. It's dead. It has to be removed. That's how bad it is. That's why the news call it flesh-eating bacteria. Next, we have toxic shock-like syndrome. Starts with non-specific symptoms: vomiting, diarrhea, chills, and then it can progress to toxemia, bacteremia, shock, multi-organ failure, and death. All of these are suppurative diseases. How about non-suppurative? Rheumatic fever and post-streptococcal glomerulonephritis. Rheumatic fever is not the same as rheumatoid arthritis. They are different. Rheumatic fever affects your joints and your heart. And when it affects your heart, it can damage all layers: endocardium, myocardium, and pericardium. We call this pancarditis. Post-streptococcal glomerulonephritis is a nephritis. The kidney is literally injured and shedding tears of blood. You have blood in the urine, hematuria. So let's take a deep breath and dive into the world of diseases. And we will start with strep throat. Pharyngitis time. You're exposed to the stinking bacteria, usually with a contact with a sick person. You got some group A beta hemolytic streptococci. 2 to 4 days later after the exposure, you start developing sudden onset of fever, sore throat, and headache, exudative suppurative pharyngitis, tender cervical lymphadenopathy, And I've told you before that when the lymph node is big, try to establish is it painful or painless. Painful is more likely to be infection. Painless is more likely to be a tumor. We said before, infection is painful, cancer is painless. Be very careful because viral pharyngitis can be very similar to this, so you will need some lab tests to investigate the cause of the pharyngitis. Next, we have scarlet fever. I have pharyngitis, I have rash. The same pharyngitis and then rash. Describe the rash. Sandpaper-like rash. Where does it start? Upper chest and then it goes to the extremities. Moreover, I have a strawberry tongue. My tongue is red and it has spots in it, just like this. The tongue usually started white and then you shed that white and it becomes red. But you are not going to shed every single white spot. Some will remain indeed, giving the texture of a strawberry. Moreover, circumoral pallor, which means the rash is clear around the mouth. There is no rash around the mouth. And then pasteolines. These are rashes in the abdomen folds and in the skin folds. And they blanch when you press on them. Unlike petechia purpura ecchymoses, which do not blanch. So, scarlet fever is a pentad according to medicosis. You have pharyngitis and rash. You have fever and cervical lymphadenopathy. You have strawberry tongue, maybe circumoral pallor, and pasteolines. Complications. It's a bad pharyngitis. Can it extend? Yeah, it can extend to the deep tissues of the head and neck, causing peritonsillar abscess and retropharyngeal abscess. These are really nasty. Thanks to the availability of antibiotics, the incidence of these diseases has decreased tremendously. We are done with pharyngitis. We are done with scarlet fever. Let's talk about skin diseases seen in Strep pyogenes, and we'll start with impetigo. But I can't help myself but remind you of the difference between staph and strep. Staph is coagulase positive, strep is coagulase negative. This is extremely relevant. Why? Because if you are coagulase positive, you will coagulate, you will clot, you will remain in a localized area, such as folliculitis, such as an abscess, just one spot. Could be small spot, large spot, etc., but you're a spot. Conversely, Streptococcus coagulase negative. Nothing is coagulating it in a localized area. It's gonna spread. And before you know it, you got erysipelas, cellulitis, necrotizing fasciitis, or even sepsis. Why? Because they spread like crazy. How about impetigo then? Impetigo could be caused by staph or strep. And you gotta distinguish between two types of impetigo. Non-bullous impetigo versus bullous impetigo, as we have discussed in previous videos. I have a separate video about this distinction. Two children came to you. Both of them have skin lesions. Both of them have honey-colored crusting on their skin. The first dude has papules and pustules. The second has bullae and blisters. The first one could be caused by staph or strep. The second one is only staph. The first one could be treated topically or systemically. The second one is only systemically because it's severe. Bullae and blisters. This is dangerous. The first is called non-bullous impetigo. The second is called bullous impetigo. The bullous impetigo, the severe one, the peculiarly Staph aureus one, is a localized form of staph scalded skin syndrome, which we talked about in last videos. Non-bullous versus bullous impetigo. Non-bullous, Staph aureus or Strep pyogenes. Bullous impetigo, only Staph aureus. The first is papules and pustules. The second is bullae and blisters. Both of them can give you honey-colored crusting. The first one could be treated topically or systemically depending on the severity. The second one is usually severe and you need systemic antibiotics only. Not topical. Topical is not gonna work. There you go. The bullous impetigo is caused by a toxin produced by Staph aureus, and this is just a localized version of staph scalded skin syndrome. Next, we have erysipelas versus cellulitis. Both are Streptococcus pyogenes because it's coagulase negative. They spread. They are not localized in one spot. They are all over the limb. Erysipelas. Let's break that down. The first part means red, like erythro, and pella is the skin. Basically, your skin is red. Oh yeah, because I have an infection. In cellulitis, it is the skin and subcutaneous tissue. The border of erysipelas rash is very well demarcated, unlike cellulitis. Erysipelas is more likely to be raised off the skin. Cellulitis is not as raised. Which one is worse? Of course, cellulitis, because it can progress into necrotizing fasciitis. Inflammation of your fascia, which is way below the skin, with necrosis, sometimes even gangrenous necrosis, which will require surgical debridement plus or minus amputation. And of course, don't say, I'm gonna give the patient oral amoxicillin. Shut up, shut up, shut up. Intravenous and call the surgeon. This is serious. This can kill you from multi-organ failure. This is what corporate chills call flesh-eating bacteria. Next, we have toxic shock-like syndrome. Please remember the toxic shock syndrome caused by staph. Do you remember this story? Do you remember my purpura fulminans? Do you remember the story of the dirty inoculation that happened in 1928 Australia? Do you remember my tampon-wearing neurosurgeon who got fever, hypotension, diffuse generalized macular erythematous rash involving the palms and the soles as well, oliguria, elevated BO and creatinine, skin desquamation, multi-organ afflictions with bilateral lung infiltrates? This was toxic shock syndrome caused by staph. Why did my hero succumb to her illness? Because most doctors are doofuses. And because toxic shock-like syndrome can lead to hypovolemic shock with multi-organ failure due to decreased tissue perfusion. Let's compare and contrast between toxic shock syndrome caused by Staph aureus versus toxic shock-like syndrome caused by Streptococcus pyogenes. Both of them have toxemia. However, the one caused by staph does not have bacteremia, which means it's not going to respond to antibiotics because they are called antibiotics, bio, life. They are anti-living. They are antibacteria. When you have no bacteria in the blood, antibiotics are not going to do anything here. They might prevent the secretion of new toxins, but they are not going to cure the toxins already in your body. Versus Streptococcus toxic shock-like syndrome, which has bacteremia and toxemia. This patient will have bacteria in the blood, therefore antibiotics are more likely to help here than here. See, medicine makes so much sense once you understand what the flip you're talking about. Third, staph toxic shock syndrome is not preceded by severe skin infection, unlike strep, usually preceded by severe skin infection such as necrotizing fasciitis or a bad cellulitis. Coagulase positive, coagulase negative. Think. Don't forget that toxic shock syndrome is one of the rashes that involve the palms of the hand and the soles of the feet. There are not many rashes in medicine that can cause this.
But hey, medicosis, these are 10. That's a lot.
Yeah, 10 out of how many? Out of hundreds. So streptococcal toxic shock-like syndrome start with non-specific symptoms such as vomiting, diarrhea, fever, and chills, not to be confused with Netflix and chill. Skin disease, and then toxemia and bacteremia, and then shock, and then multi-organ failure and death. So we've talked about all of this. Don't forget peripartum sepsis, pneumonia, and lymphangiitis. Now let's turn our attention to the non-suppurative diseases caused by strep pyogenes. First, rheumatic fever. We start with a pharyngitis caused by strep pyogenes, and then later I develop rheumatic fever.
Hey, medicosis, can I start with streptococcal skin infection and then develop rheumatic fever?
No.
Why?
Because the strep that causes pharyngitis and the strep that causes skin infection are not the same strain. Rheumatic fever happens as a complication of the strain that causes the pharyngitis, never from the strain that causes pyoderma. Big difference. And if you are super duper sophisticated, you will recall that rheumatic fever is a type 2 hypersensitivity reaction. Antigen-antibody complex, and since this is type 2, is Cy2 toxic. Cy2 toxic is type 2, and Cy2 toxic means that the antigen and antibody are kissing each other on the surface of the cell. In this case, it's your heart cells, joint cells, etc. This is the pathophysiology of type 2 hypersensitivity reaction. Please pause and review. If you have any problems, watch my video called Type 2 Hypersensitivity Reaction. Do you remember the M protein, which is a structural component of strep pyogenes?
Oh yeah, medicosis, I remember it. It's present at the cell membrane of the bacteria. It's an alpha helix, 2 polypeptide chain, so it's protein in nature
because most of the active things in your body are proteins or peptides. This lovely protein, just like the usual, has an N-terminus and a C-terminus. The C-terminus is in the cytoplasm of the bacteria. The N-terminus extends upwards, and this determines the antigenic difference between different types of strep. And that's why rheumatic fever does not happen because of all strep strains, only some of them. The M protein is nasty. It enables the streptococcal bacteria to inhibit phagocytosis. Your body will not be able to eat those suckers. Moreover, the M protein can confuse your body. Your body will start attacking your own cells instead of attacking the bacteria. Why? Because of something called molecular mimicry. The M protein of the bacteria looks very similar to your heart tissue. At least this is how the theory goes.
Okay, medicosis, which M protein class are you referring to? Class 1 or class 2?
Well, when we talk about rheumatic fever, I'm referring to class 1, i.e. the exposed M protein. Rheumatic fever, let's review. First, do not confuse rheumatic with rheumatoid. They are not the same. If you want to know what rheumatoid is, check out my rheumatology playlist. I have many videos on rheumatoid arthritis. But today we're talking rheumatic fever, non-suppurative complication of streptococcal. Streptococcal what? Pyoderma? No. Skin infection? No. Only pharyngitis. Which streptococcal? Group A beta-hemolytic streptococci that possess the M protein. Which class of M protein? Class 1, the exposed M protein. Usually rheumatic fever happens in a child during winter months or autumn or fall months. Risk factors include living in poverty, living in the slums, poor hygiene, many sick contacts, etc. The poor kid is gonna develop sore throat, and then later, strong antibody response. That's the molecular mimicry, that's rheumatic fever. Rheumatic fever is not just the joints, it's not just the heart, it's many organ, and these are the classic Jones criteria. J, joint disease. The O looks like a heart, so it's carditis. The N is nodules, the E is erythema marginatum, S is Sydenham chorea. Describe the joint disease. Shifting migratory inflammatory polyarthritis. My joint is inflamed, and then it gets better. And another joint gets inflamed, and then it gets better. And then a third joint gets inflamed, and it gets better. It migrates. Next, describe the heart disease. Pancarditis, endocarditis, which involves the valves. Myocarditis and pericarditis. Describe the erythema. It has a margin, erythema marginatum, redness with a margin. And then the classic Sydenham chorea. Rarely seen, but if you're an excellent doctor, you shall never miss this because the story is classic, it's unbelievable. And since I was born in Egypt, let me tell you the story of the classic Sydenham chorea in the classic Egyptian mother that lived in Egypt 55 years ago. I'm not saying that every Egyptian mother is like this. I'm trying to make medicine easy and fun for you. The story goes like this. Hey kid, go get me a glass of water, said the mother. So the kid goes to bring the glass of water for his mother. The kid goes to the glass, grabs the glass of water, and then brings to the mother. Just before reaching the mother, the glass falls off his hands. So his mother yells, "What did I tell you? Be very careful when you're holding the glass of water. When are you going to learn? Now clean this mess and go get me another glass of water." So the kid repeats the same thing. But now, unlike the first time where the kid was able to walk for about 5 meters before reaching his mother, now the kid is going to walk like 3 meters and drop the glass of water. And then the mother will yell again, "I wanted you to be a neurosurgeon. How in the world are you going to be a neurosurgeon and make mama proud if you're not even capable of holding a glass of water? Now clean this mess and do it again." So the kid goes to bring a third glass of water. And then after walking 1 foot, he drops the glass. Then the mother realizes something. Maybe, just maybe, her kid has a problem. This is classic Sydenham chorea. Did your professor tell you about these stories, Cody? Medicine is very interesting. Master your craft so that you can help patients. Next, let's talk about post-streptococcal glomerulonephritis, also non-suppurative. Now, I have a separate video about acute post-streptococcal glomerulonephritis where we get into details, but today we'll review it very quickly. If you want to dig deeper, the video is available on my 5-minute review playlist and on my nephrology playlist. Let's go. Nephritis, post-streptococcal glomerulonephritis. Itic means inflammation. The kidney is inflamed and shedding tears of blood into the urine. Nephritic syndrome, acute inflammation of the kidney, and we have classic 7 features. You don't have to have all of them. What do we have here? Hypertension, hematuria, jugular venous distension, oliguria, mild edema and proteinuria, elevated BUN and creatinine. Don't forget the blood in the urine. That's the hematuria, the most important thing. Can I find red blood cell casts in the urine? Yes. Can I find dysmorphic red blood cells in the urine? Yes, because it's a nephritic. The tubules of your kidney and the glomeruli are inflamed. Nephritic diseases are many, and they include acute post-streptococcal glomerulonephritis, where the patient is mostly young. Unlike rheumatic fever, which has to be caused by pharyngitis, post-streptococcal glomerulonephritis could be caused by pharyngitis or strep skin infection. When your kidney is losing blood, it is nephritic syndrome. When your kidney is losing protein, it is nephrotic syndrome. In acute post-streptococcal glomerulonephritis, your kidney is losing blood in the urine. Why? Because we have subepithelial immune complex deposits right here. See, the epithelium is called the podocyte. Under the epithelium, subepithelial. Here is an immune complex and then a space. Here's an immune complex and then a space. Here's an immune complex and then a space, an immune complex and a space, giving you this lumpy, pumpy pattern under electron microscopy, especially if you add immunofluorescence. 2 young patients can come to you, and the history is very important. Both of them came with pharyngitis, followed by blood in the urine. The question is, after how long? If the time between the pharyngitis and the nephritis is about 1 to 4 days, sometimes they happen together, i.e. short period of time, this is IgA nephropathy. But if we have to wait for weeks before this happens, this is post-streptococcal glomerulonephritis. Big difference. How do you remember medicosis? Look at the word. It's called post-streptococcal. Post. It takes time. It takes longer. Acute post-streptococcal glomerulonephritis, group A beta hemolytic strep. I start with a pharyngitis or a skin infection or both, scarlet fever, and then 1 to 3 weeks later, post, I have blood in the urine. It's a post-infectious glomerulonephritis. Signs and symptoms: hypertension, hematuria, jugular venous distension, oliguria, periorbital edema, and proteinuria. Diagnosis: antibodies against DNase B. Maybe or maybe not antibodies against ASO, depending on whether the first infection was a skin infection or a pharyngitis. Because cholesterol in the skin destroys ASO. That's why if I had skin infection before the nephritic syndrome, ASO will be negative. But if I had pharyngitis before the nephritic syndrome, ASO will be positive. Something that your woke professor will never tell you. Under light microscopy, my kidney is diffusely inflamed. Under electron microscopy, I have subepithelial lumpy pumpy pattern. The prognosis in kids is excellent. In adults, not so much. Treatment is antibiotics, supportive care. Manage the hypertension. You may need diuretics. This is nephritic syndrome. Please pause and review. The characteristics of Streptococcus pyogenes were discussed before. Don't forget the beta hemolytic. So here is my beta fish. Catalase negative and coagulase negative. Today we're talking about the diseases caused by Strep pyogenes. And this slide came from my friends at Picmonic. Link in the description. Diseases, let's go. We have pyogenic diseases. Here's the pygene, which include the following. Pharyngitis, here is pharaoh. Cellulitis, here's the cell phone. Impetigo, here's the emperor tiger. These are pyogenic diseases versus toxigenic diseases, which include scarlet fever. Look at my strawberry tongue. Remember the erythrogenic toxin. Scarlet fever has the strawberry tongue, circumoral pallor, sandpaper-like rash, and of course the fever beaver. These are pyogenic. These were toxigenic, and don't forget my immunogenic, which include rheumatic fever, here's the Roman fever beaver, and acute post-streptococcal glomerulonephritis. Take a deep breath and let's review. Streptococcal diseases are suppurative and non-suppurative. The suppurative could be pyogenic or erythrogenic. Let's lump them together. You have pharyngitis, skin diseases, scarlet fever, which is both. Here are the skin diseases. Here's the toxic shock-like syndrome. Pause, take another deep breath. Then we have non-suppurative immunogenic diseases. In the heart, acute rheumatic fever, remember your Jones criteria. In the kidneys, post-streptococcal glomerulonephritis, remember nephritic syndrome and hypertension, and periorbital puffiness. While these topics are fresh on your mind, check out my antibiotics course on my website. 40 videos about antibacterials, antivirals, antifungals, and antiparasitic medications. You can download them today. And you will never understand kidney pathology without mastering kidney physiology first. I have another course about renal physiology on my website. After mastering kidney physiology and then kidney pathology, learn kidney pharmacology in my cardiac pharmacology course where we talk diuretics. Don't forget that painful lymph nodes are infected, but painless lymph nodes could be cancer. Speaking of cancer, I have an anti-cancer pharmacology course. And you can get a 50% discount by using promo code ARDS. If you want tutoring, I can tutor you one-on-one. I can beat the living medical knowledge out of you. Just joking, I love you. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.